Hi, Jim Leffler here, continuing to lead the Introduction to Psychodynamic Psychotherapy Technique course. This is the third session. Today we'll talk about transference and both look at the historical idea as well as a present tense event that is happening here and now. As a review from the first two sessions, we're trying to remind ourselves that the definition of a psychoanalytic psychotherapy here, psychoanalytic is synonymous with psychodynamic, and if I say analyst, I mean physician or therapist as interchangeable elements. The same is true of patient or client. So psychoanalytic psychotherapy is depth-oriented, patient perspective, and we looked at the two different ways of listening, a diagnostic and a dynamic, and then that it is patient-directed. And we talked about last session about one needs to establish a frame, and then that allows the patient to freely associate as well as give freedom to the analyst within a sturdy frame to suspend judgment and remain curious with their attention. Today, we're going to now start exploring really what the rest of psychoanalysis is about. And each of these elements that I wrote here, and there are others, relational dynamics, emotional processes, attunement to the therapeutic process itself, really make up whole fields within psychoanalysis. So there is a school called the relational school. The emotional processes school favor affect forward, somebody like Andre Green or Antonio Ferro. And then the attunement to therapeutic process, maybe something like Kernberg's transference focused psychotherapy. And there are other psychic processes, but just to point out that when one explores, we're going to be looking at these over the next 14 weeks, but recognizing it's just the beginning, and that people have really looked at each element that I've written here as many others, as things you can focus on. And as I was preparing today, I thought, admittedly, there is a short-term psychodynamic psychotherapy that you can look for and find and learn that actually focuses on each of these different elements I'll describe, as well as many others. But they all share this patient perspective and patient-directed orientation as being primary. So, the topic for today, transference. Freud describes this in 1912, and he kind of says that what he noted in his work was that patients will transfer onto the analyst the feelings, expectations, and templates that they have established from childhood. And going back to setting the frame of abstinence, neutrality, and anonymity creates a blank screen that the patient can then project onto. And it's the job of the analyst to trace back these transferences, these biases, these templates back to their origin in childhood. And that would be called a genetic interpretation and would be based within the concept of reconstruction, that if we can reconstruct your past through the memories that you're sharing in the present, it'll help us understand where this came from. And by gaining that understanding, linking what you're doing now in the transference to what happened then, that's insight, and that will help resolve the issue. And that's a genetic interpretation. What is the historical origins of that? An example, you feel that I'll harm you just like you were afraid of your father harming you as a child. So that was Freud. And I can't speak to how he worked, but at the present, people have taken transference and moved it into the present tense. So what's happening here and now? You absolutely can make a there and then commentary that can help people organize. It can help people link. It can help people make sense of what's going on in the here and now. But the transference isn't just the replaying of old events, but it's actually being developed and happening in the room and can be commented on and described in real time. And that's actually the essence of a specific short-term manualized psychodynamic psychotherapy called transference focused psychotherapy that was developed by Otto Kernberg to treat patients with DSM diagnosis of borderline personality disorder. Now, I know, admittedly, a caveat, Kernberg has his own way of understanding borderline, but I'm not going to get into that today. regardless, so what does it mean here and now? We're going to look at the current relationship between therapist and analyst. Between analyst and patient. And I don't want to ignore that there is also a real relationship, and there's a whole literature on that as well. And that when someone says, like, you look tired or you're angry with me, that could be true because the therapist analyst can be tired, can be angry, and so that can also happen. But what we're describing here is that the analyst's tone, silence, their face, their gender, their race, apparent age can be used by the patient and will be used by the patient to construct a narrative about the therapist. And these narratives can be used to understand the patient's assumptions and what's happening in the moment that's leading to that. And then you, of course, can jump back to these genetic interpretations to give you a reason for why that may be the case, but that you're really recognizing and using the present relationship, not just the relationship of the past, not assuming that the analyst isn't contributing, to kind of think about what's happening here and now. And then a third here and now way is to think that the relationship between patient and therapist is itself a symbolization of the actual current emotional experience, that the patient's working through experiencing disappointment or sadness or joy, and that but a way that is being manifested is in the room, in the relationship itself. So that the transference not only is a projection of past templates or current biases, but actually an attempt to give voice symbol to an emotional experience. So transference in the room, like, well, why would that be? Why does that matter? Why can't we just use genetic or historical commentaries? And as I've already said, those are totally fine. It's okay. They can be organizing. They can be helpful. They can lead to some insight that can lead to growth. And I won't get into today. Some schools of thought still think that is the main mechanism. But questions that would be around that. What does this remind you of? Is this familiar to earlier relationships? But when you bring it into the room, the here and now, thinking about the current relationship and the possible emotional experience that's occurring between analyst and patient, we can think about it. If it's in the room, that means we can work on it, that it isn't fated, that it didn't happen in the past and now you're doomed to repeat it forever, but that it's living and open to change because it's here with us. Now that the ability to enter into the change may be pretty tough depending upon what happened to set the kind of transferential aspects in motion, but bringing it into the here and now allows it to be worked on. And just as a quick thought about that, so we have this hypothetical patient, all right? It's a depressed female in her 30s, and she arrives 8 minutes late. And she says, I almost didn't come. I know you'll think I'm a difficult patient for showing up late. Now, in your mind, again, these are options. I'm not telling you which one is the right one, and I think any of them could be reasonable given the circumstances, but just kind of thinking about that situation. A person comes in, they tell you I almost didn't come, and I know you'll think I'm difficult. So logistics, you could just shift to a very practical thing. Oh, well, what kept you? What led to it being 8 minutes late? You're not usually that way. Reassure her, focusing on the second part. I wouldn't think that you're difficult. Like, what? I wouldn't think that. You can use a genetic interpretation to help with reconstruction, to help build a framework or a narrative. Has anyone called you difficult before? You could bring it into the here and now situation and just wonder aloud that you've noticed. You're noticing you think I'm going to think you're difficult, which opens up the here and now opportunity to wonder about what is happening between you and the patient right now. You can also say nothing and notice that the patient has just announced that before the session even started, you had already passed judgment on her, and kind of can hold that in mind and be aware that you've just been given a glimpse into how the patient's mind is working, and any of these could help you then explore that with her. Okay, thanks.